So now that we've solved the whole problem of the primary care in 45 minutes, we're now going to solve the problem of the waiting list, it seems, right? No mean feat, of course. So, of course, as you know, there's a long waiting list. NHS is estimated to have between 7 to 8 million people on elective lists at the moment. Outpatients, as you know, it's a real burden, a problem with DNA rates, with people oppressing the system. I mean, I, in my clinic, still see patients who've been waiting over 18 months to see me. And I said before, some of them have forgotten why they've come to see me. I have to kind of remind them from the letter that was referred 18 months ago. But actually, it's not a great service that we provide. Wait lists have become almost routine, accepted as part of the health service. But in reality, philosophically, should we have wait lists at all? If someone's ill, wouldn't you want to be seen straight away with your problem? If you've got a hernia, it's painful, why do you have to wait 8 months to be seen and then a year or so waiting for an operation? It adds problems to the economy. It adds to problems of the workforce. So I think we've got to think about a new model going forward. The first thing, of course, is understanding how we optimize, how we make it better, make it easier, more efficient. Hopefully, both Alex and Liam will give some of the solutions, hopefully. Thank you so much.
Thank you.
Good morning, everybody. I guess for the eagle-eyed among you, you could probably tell that I'm not Redmond O'Leary. I am actually a late stand-in. My name is Clive Rumsey. And I am the sales director for Intersystems. I'm joined today by Alex Danceville, who's the CTO, or Chief Technology Officer for HBS UK. As we've gone through, the plan of today is to talk you through our experiences and a case study detailing cutting outpatient waiting times and reducing admin. So first of all, Alex, perhaps you could start by just telling us a bit about yourself.
Bit of personal background. Sure. Good morning, everybody. And thank you, first of all, Clive, for stepping in at short notice to help me out here. So a little bit of personal background then. I'm an engineer by training. I think my family would say that's firmly built into me. And I didn't start out in healthcare at all. I spent the first 10 years of my career working for ARM, designing microchips, the things that are at the heart of all your smartphones in this room. And I kind of came into healthcare a little bit by accident. I joined the board of a small lab instrument business in Cambridge, where I'm based. And they just won a really interesting contract from the government's cell and gene therapy catapult. It's just at the point where CAR T therapies were starting to demonstrate some amazing results. And I got introduced at that stage in my career to this incredible science of reprogramming the human immune system to go and kill cancer cells. And I remember being blown away by that. But I also remember starting to be exposed to patient stories. And I think I probably came to realize this a bit later than most of the people in this room, that just how incredibly rewarding it is. We're going to focus on lots of intractable problems today, and in the healthcare industry it has some really difficult challenges. But I also remember that at the end of it, it's the patients that we help, and we're all that small cog in that quite amazing machine. So when we sold that lab instrument business to GE Healthcare, or I got into sort of drug manufacturing and sort of effectively into the pharmaceutical world, when that came to an end, I was looking for an opportunity to get closer to patients. And that's when I found HBS, and I saw the opportunity in what they were doing. I was really excited. It was a very small company at the time. It's quite a lot bigger today. I'm going to tell you a little bit more about it. But I saw a huge opportunity to use technology to help with patient care.
Okay, Alex, in relation to HBS UK, can you tell us, I guess, a little bit more specifically about what you're doing in the UK?
Yeah, so what do we actually do? So we're all about cutting waiting lists and reducing waiting time, and so we partner with the NHS to do that. And I think there'll be a lot talked about in this conference. It's been a national conversation for many years now. Waiting lists are unacceptably high, right? 7.5 million and climbing. And despite all the efforts that everybody's been putting in, waiting lists continuing to rise. So what do we do about it? Well, we've got really 3 parts to our solution. I think we've got a really comprehensive way of addressing this. So first of all, there's administrative validation, right? So because so many patients now, 52-week waiters, even 78-week waiters, they've been on that list for a very long time. And so the first thing we do is we contact the patients and make sure that they do actually still need to be seen. And a proportion of patients have found another solution. Maybe in the good case, the problem has resolved itself. Fantastic. In other cases, patients have been forced to go private in order to get treatment, and a small number of patients will have died. So we need to validate those waiting lists as our first point. Then we get into the bit that I'm much more excited about, right? The digital assessments. That's where we use our Lucy platform to help assess patients digitally. And that involves, it might be video appointments, it might be telephone appointments with consultants. It's also asynchronous assessments. So we have a sort of smart questionnaire that patients complete at home. The answers evolve as you in response to as you answer them. And the purpose of that is really to make sure that we hoover out of the patient the most comprehensive medical history that we can possibly get. Everything that would happen in a face-to-face appointment, an interview with that patient, we want to get that history out. And I think actually some of the consultants have said to me that even in a face-to-face consultation, you can have this experience. Patient is walking out of the room, doors closing behind them, and just as the door's closing, you're thinking, I didn't ask key question. Obviously having that structured approach really helps with that process. But when we talk to trusts about the problems that they're facing with the waiting list, we're always hearing about capacity. We need more capacity. How can we get more capacity? And what the digital assessments do, and we've demonstrated this, they take less than half the amount of time that the face-to-face appointments do. So that immediately means the consultants can see nearly twice as many patients. And then they also create capacity because you can do this work at all sorts of times and from all sorts of different locations. And that means that sometimes we can bring in consultants from other trusts where that's appropriate. It also means that it fits much better around modern busy lives and childcare commitments and maybe even the odd private clinic that a consultant needs to squeeze in around. So these digital appointments create capacity. But you will all know, right, problem solving in the NHS is a little bit whack-a-mole. So you fix a problem over here and another problem pops up over there. And I think what we've found in this space is that, okay, we've validated this waiting list, we've assessed everybody digitally, we've made a dramatic impact on that waiting list, but we've now pushed a whole bunch of people who need minor operations or they actually need surgery, so they're going on those waiting lists, which are also under a lot of pressure. And on top of that, although we're generally dealing with routine waiting lists, we generally find cancers. We find cancers on the routine waiting list, and that is a huge tragedy for the patients who are on those lists because they're getting that news pretty late. And it's also a problem for the hospital we're helping because we've just pumped that person right to the top of an urgent queue. They need to be seen very, very quickly. So the third part of our business and trying to make sure we've got a full solution to this problem is we have an insourcing arm. So we arrange a catch-up work at the weekends when theatres are not being used. And mostly we work with the hospital's own staff to support that, but we do the administration and the setup and we make sure that patients are prepped and organise it and so on. And in that way, we can help deal with the problem that we just created by doing all of those assessments. So I like to think that we've got a really pretty comprehensive answer to the waiting list challenges.
Yeah, I was going to say, Alex, that sounds as if you have a particularly comprehensive solution. I guess the assumption would be that you're in big demand?
So you'd have thought so, right? And I think what... Hello? Okay. Why is it always me? So I'm a technologist, right? And I come up on stage and the technology breaks. There is a long history of this happening. I apologise for that. Right. So let's pick that up. So we ought to be in big. It's gone quiet again. I hope you can hear me. We ought to be in big demand, right? And we certainly find that there's lots and lots of need for our services, but there are also a lot of challenges. And I think in recent conversations, the NHS has been quite open about not being the easiest organisation always to engage with. So you look at the things that we have to do. We some significant barriers, right? There's obviously the procurement frameworks, there's the regulatory standards, there's the clinical governance, and then there's the incredible complexity of the way that funding works inside the NHS. And we'll probably come back and touch on that in a little bit. But as a business, we've put a huge amount of time and effort into making sure that we're on all the procurement frameworks. So I think 11 or 12 at the last last time I counted. That we're DSPT Toolkit and DTAC certified and Cyber Essentials Plus. We're ISO 9001, 27001. We've done medical devices. I think I see someone from Deviceology in the background there, so thank you, Richard, for your help with some of those things. We've met some of those challenges. The funding piece, I'm not even going to try and talk to. If anybody can explain it to me, then I will be happy to buy you a coffee after this talk. Please come and find me. But even when you get through all of those pieces, you've then got some of the operational challenges that we're going to talk about here. And we said in this talk it was about reducing admin. So let's talk a little bit about some of those operational and administrative challenges. I don't know many people who enjoy administration, right? You know, I won't do a quick survey there, but certainly not high on my list. And I think clearly the purpose of the NHS as an organisation is to provide care to patients. But in order to do that, you have to deal with quite a lot of record keeping, a lot of administration. You've got to maintain contact records and organise rotas and set up clinics and book patients into clinics and all of those pieces of very essential administration. And I think over the last decade or so, there's been really serious investment in trying to digitise a lot of that process, right? Bring in electronic systems. And I think I would probably say that in a lot of cases, what I see happening is what I call paper on glass. So we've taken a paper process, and I'll give you the example. 20 years ago, go into reception at a hospital, and the receptionist would have a whole set of questions for me, and he or she would be writing those down on a paper form, and then probably that paper form would go into a filing cabinet somewhere. You do that process today, walk into reception, and of course the receptionist is furiously typing while I talk to them, and they are entering that information into an electronic form that's probably not that different from the paper form. It's just on the computer screen. And now it goes into a database. And yes, that's better, right? We're less likely to lose that record. It's better protected, and it's easier to search, and it's easier to get information from. But it's a relatively incremental step. We haven't really fundamentally changed the process. And the bit that I think I'm most excited about with what we're doing with our Lucy platform is that it's really realizing that benefit of digital, that you get patients to do things for themselves. And that's when you get the real benefits of the process change. So really excited about the opportunities that presents.
Sorry, just to interrupt. Alex, in terms of the 58 steps, could you just talk us through a bit more detail on that?
Keep me on track. Thank you, Clive. So, yes, 58 steps. So this was a trust we were working with in dermatology, and they were super happy with the progress we'd made with the waiting list. The clinical results were good, and the patient feedback was really, really positive. But the admin team was not very happy. And we were trying to understand sort of why, what's the issue. And they were explaining this, and they actually sent us a guide with screenshots and steps of what they were doing, these 58 steps for every patient that we were assessing for them. And I remember starting to understand this, because what's at the heart of the reason for that administration is something that database engineers call referential integrity. I quite like that phrase. See if you can get that in. 10 points to anybody who can get that in over drinks tonight. Referential integrity. What it means is that any record in the system is only valid if all the records that it points to are also valid. And what that means for those administrators is we want to say, Mrs. B has been assessed by us and she's been discharged with a management plan, and her RTT code is whatever it is, 003. In order to enter that into the system, the administrator has to have a reference not just of, okay, well, that outcome came from an appointment, so we should have an appointment record. Okay, and the appointment had to be in a clinic, so we need a record of the clinic. And the clinic is driven by a rota, and it's got a set of clinicians assigned to that rota. All of that data has to be entered as well. And that's how you get to 58 steps. And it would seem that the local staff in the hospitals don't have a mechanism to be able to bulk update or rapidly upload this kind of information. So they're doing it one at a time for every single patient. And that really creates a pretty unworkable process for the trust. Your turn now.
Yeah, my turn now. Yeah, I was going to say, so listening to that, it sounds, obviously, we're a technology business, you're a technology business. It sounds very much as if the solutions technology is around better levels of integration.
Indeed. So that leads us on to this picture. Believe me, I'm not here to bash trust IT teams. They have an extremely difficult job. If you work in hospital IT, you know what I'm talking about. It's generally a relatively small team supporting 10,000 users plus, spread out across multiple sites, with an increased now amount of homeworking as well, to make things more exciting. And if you look at the systems that they're needing to support, the complexity of what users are doing is way more than the usual IT of, I don't know how to print this, please, or my laptop has just lost all of my data. Although, of course, they are dealing with all of that multiplied by 10,000 users as well. They're doing it in the context of being asked to deliver major infrastructure improvements at the same time. And pretty much everybody that I talk to in hospital IT, they're either implementing an EPR for the first time. I don't know how many hospitals here represented doing that. Or they're ripping out the one that they've already implemented in order to do it again. And those are massive projects, multi-year efforts that the IT department's being tasked with. So they're dealing with all of that. I remember reading, actually, I looked at a trust publishing one of its sort of improvement reports, and the IT department was talking about big success that they'd had. They've managed to reduce, I can't remember exact numbers, but it was something like 568 different software systems in the hospital, and they'd got it down to 330. Woohoo! So that was a major success for that. And you look at that and you think, 330 systems. That's probably more than the number of people in the IT department. So how on earth do you cope with that? And as I understand it, they have to use pieces of software in the hospital to get all of these different systems to talk to each other. Funnily enough, there's a company here that helps with that, right, Clive?
Yeah, thank you very much, Alex. I perhaps should have provided a little bit more detail in the intro. For those of you who aren't familiar with InterSystems, we are a global provider of healthcare solutions and data platforms, really designed to support better patient outcomes, but also to provide support for companies like HBS UK to build platforms on and build technology on. And I guess from our perspective, at the time this is going out, I think we're currently working with about 120 so of the UK NHS trusts. So we have a huge amount of experience in terms of working with overstretched and in-demand NHS IT teams, and understand the kind of pressures those teams are under. From HBS UK's perspective, could you maybe give us a few more examples about how you manage those relationships for better outcomes?
Yes, I realise I've been laying out all these problems and I haven't shared a lot of solutions. So let's talk about a case study of what we have been able to do and how this has worked. And I'm going to use an example from North Cumbria Trust that we've been working closely with. And I guess the first question is, why have we been able to do integration there where it has been challenging elsewhere, given all these challenges with the busy IT departments that I've been laying out? And I think it's probably helped us that it is a smaller trust, and it's also a very geographically spread out. So they've got 10 hospitals spread out over a large area. The dispersion of the patient population is large, which means that the digital technology is particularly helpful in that environment. And like a lot of trusts, they've got some acute waiting list challenges in particular specialties and difficulties with capacity. And I think what probably helped us with the engagement there is that from very early stages we were stressing the importance of dealing with the admin problem and that we would need to integrate with the trust systems at the word go. And we had some credibility that we were able to bring into that from our previous engagements. And I'd also acknowledge InterSystems here as well. It brought some credibility to that process for us because of the huge experience they've got in integrating to hospital systems. So we were able to put together a small team. And to give you an idea, that the effort from the trust side, it involved 2 people from the IT department, one networking specialist for a couple of weeks, and one who was involved on the actual integration piece for about 6 or 7 weeks. Most of that time spent actually testing rather than doing development. And I think that's elapsed time, not effort. So if we were to look at person days of effort, probably 5 or 6 days of actual integration work to get this up and running. And what we produced, I'm going to show you a patient journey. I'm going to use Winnie the Pooh. So Winnie the Pooh is my patient who's been waiting to see a urologist at North Cumbria. And what happens to Winnie from the trust perspective, they do what they would do for any other clinic. They on their PAS system. It's a really beautiful bit of software, isn't it? There, the PAS system that they've got on the top left-hand side. That's their PAS, and they book Winnie into a clinic, just like they would do any other clinic. The act of doing that refers Winnie over to HBS UK. Electronic messages come over to the Lucy platform. We pick up that patient, create their record, create their case, and the first thing we do is send a text message to Winnie. So it says, "Dear Mr. Pooh, it's North Cumbria NHS Trust. We know you're waiting to see a urologist. Click here to answer our questions." And because at this point, Winnie's only going to be providing us with information. We're not sharing any information back. We can address some of the digital access challenges here. We can try and make it really easy to get Winnie into the system. So there's no registration, no logging in, it just asks you to confirm your date of birth and your NHS number, and then you get straight into answering the clinical questions that we've got about their condition. Winnie will need to use NHS login later, because you can't access any patient records without a full login. We can make that first step a lot easier. It's a sort of similar model you might have seen in retail these days. They've moved to guest checkout. When you do your Christmas shopping, you don't have to register in advance, right? You do your guest checkout, and it says at the end, would you like to create an account? So that's the approach that we use here to lower the barrier and get people on board. So when he puts in those details, goes through our normal digital assessment process, which is all managed in the Lucy platform. And then critically for the trust, the data comes back electronically with the RTT codes. It's all outcomes correctly, and it all goes into the trust's reporting structure. So that is, in a very simple nutshell, what we've been able to do in North Cumbria.
And I guess for the audience today, first of all, that's fantastic. Walking through those steps really brings it to life, and certainly use of Winnie the Pooh as well. And in terms of for the audience today, what are the kind of key learnings you've taken from this journey?
Well, I think it's a really nice example. I sort of finish with a happy picture, if you like. What I think we've learned is that getting these integrations right is absolutely critical to being an effective partner. We want to partner with the NHS. We know that there's some real challenges in the waiting list. We know we can help, but the admin creates a major barrier, and to solve that integration is absolutely key. So I think we're excited about the results that we've been able to achieve in North Cumbria generally. Just to give you a bit of a flavour of the patient impact, I think in the first cohort there were about 1,100 electronic referrals that came over to us. So that's patients for urology who'd been waiting, I think more than a year to see a urologist. We're able to turn those around incredibly quickly. So I think the mobilization for this project was something like 8 to 10 weeks, and then the assessments were happening. Patients were getting seen within a couple of weeks of being referred to us. And then we were able to deliver, I understand the figures are something like 35% clock stops on those waiting lists. So made a very significant impact on the waiting list problem in that area. And I think key to achieving that was having that integration in place and that engagement with the local IT team to make it work. So really proud of the results.
Alex, that's fantastic. It's been, I guess, really insightful and really exciting to be able to showcase such an innovative solution and one that's delivering such great outcomes. I guess in terms of the audience today, does anyone have any specific questions?
Hi.
Alex, any suggestions for companies trying to engage with the NHS, and what strategies should they use to get into the market?
Can I say persistence? So I wish that there was a magic answer to that one, but I do think there's more recognition now. As I mentioned, I've heard more talking from the NHS side about what can we do to make it easier. I think having those regulatory pieces in place is absolutely critical. So if your business needs to invest in ensuring that you've got all the governance structure, you've got all the evidence, because we all need to know that it's going to be clinically safe and effective. Beyond that, lots of persistence and small starts and trials, and keep working at it.
Would you go local first or go big and go national?
Well, we're asking that question ourselves. I think I would start local, and North Cumbria is a nice example of us doing just that. So we are very excited about a potential national programme around dermatology. But I think we start local.
Anybody else?
Hi, this is for Alex. How long does it take to integrate Lucy with Trust that you worked with? What's like the estimate time? How long did it take the process from start to finish?
Yeah, so I think it was about 10 weeks elapsed, and a huge, you think about how that time broke down, I seem to remember waiting quite a long time at the beginning to get BT to open the firewall, nothing to do with the trust, and then getting BT to change because they hadn't done it properly and do it again. So I think that was the first 2 or 3 weeks. And then after that, a program of having the administrators in the trust sort of try out the process and make sure that everybody was comfortable with how it worked and tested it. So I think, 10 weeks start to finish. In terms of actual effort, 5-6 days of person effort, it wasn't a big piece of work. And that's something we really want to emphasize with everybody. It's the big bit is getting the engagement, and from our perspective, getting the keys, getting the actual sort of access controls opened up. Once that's done, it is relatively straightforward.
Thank you.
Any more questions? Oh.
First of all, thank you, Alex, for your insights. I just wanted to ask, I think when you opened, I'm not sure if it's because, I'm not sure if I didn't capture it or maybe you didn't get around to sharing it. I think when you opened, you said that there are 3 things kind of, to tackle waiting lists. First one was administrative validation. Second one was digital assessment, Lucy. What was the third one?
All right,
It's
so
blank.
thank you. What it's often called insourcing. So essentially, it's the physical part of the service, and we talk in our business a lot about blended care. So I'm a digital evangelist. I think digital is great, but we haven't yet figured out a way to do any surgery from people sitting at their computers. So for those patients, having identified that a subset of that waiting list needs something cut out, let's say it's a dermatology waiting list and we've got skin lesions and they need something removed. We've just added to another waiting list of surgery to have those things done. So what our team will do is come in at the weekend and help to organise those operations when the theatres aren't being used at the weekend. I think you need all 3 bits to actually address the waiting list challenge. Otherwise, you just move the problem. Thank you.
Any more? No? Oh, one at the back.
How are we for time?
We done for time?
Last question.
Thank you, it's really interesting. Just a quick one. The start of all this and the biggest block for most people is impactability on staff. So how do you do that side of engaging the staff and getting them on board?
Are you asking about engaging with the trust staff? Sorry, the
Right from
microphone's
the
not very
beginning.
good.
Most staff, senior nursing officer for NHS England a while ago said, we don't want tech, we're too overloaded, we're too busy. Not recognising that tech is going to reduce their workload and give them a lunch break, rather than searching for a piece of equipment that's lost, for instance. So impactability on staff is a very key part of the process of engaging with the NHS.
Yeah,
Without them, you're not going very far.
So I very much agree. So I just reflect back because I think the microphone was a bit challenging there. I think the question was about the impact of technology on local staff and the change that you need to get through. If you're trying to bring in some new technology, it's not about the technology, it's always about the people and how do you get them to use it. Now, with what we're doing, because we're a partner, mostly the technology is being used by our staff. And what we've done for local staff is, as I showed you on the screen with Winnie the Pooh, they're using the same, I'm sorry, pretty horrible technology that they've already got booking into their PAS system. So we don't quite have that challenge. But when we're bringing more and more consultants to use our platform and run the assessments on our platform, and then we do have the engagement piece, and we work really hard with those consultants to make sure that they know how it works and that it's a nice, simple, straightforward system to use, and they get lots of feedback from us on how they're getting on with it. So the usual sort of change initiatives.
Right.
Sorry, short answer to a complicated question, but I'm aware that we're over time.
Yeah, I think we're running over on time. So, like I say, if you've got any more questions or you'd like to talk to Alex or anybody in Systems further, we have a stand downstairs. So feel free to come along and have a chat. Thank you very much.
Thank you. A round of applause
Thanks,
for our
everybody.
amazing panel. Thank you so much.